Kia ora, and welcome to this presentation for HSC 6310, and we're talking about clinical examination of the acute abdomen. And normally acute abdominal presentations are those which are acute, obviously, and severe in onset, so they've normally developed over minutes and hours as opposed to, say, days to weeks. Such presentations can range from the very benign and self-limiting conditions such as gastric infections, right through to life-threatening conditions such as dissecting abdominal aortic aneurysm. So there's various facets of paramedic practice that are going to play an important role in distinguishing between these two extremes. So this presentation is going to focus on how paramedics can use information from the OPQST or the examination of pain when we're looking at an acute abdominal presentation. We've already discussed the importance of a not to be missed diagnosis and the role of top-down thinking when we're dealing with emergency situations. So our role in this case is to sift through the not to be missed diagnosis list and make sure we have our bases covered there. So to assist with these processes, I've compiled some of the not to be missed diagnosis associated with abdominal pain. And on this slide, we're looking at this bi-abdominal quadrant. So these might at first appear to be quite daunting lists for each of the quadrants, but you'll see some diagnoses, such as intestinal ischemia, for instance, appear in each of the abdominal quadrants. So the list may not be as daunting as you first think. And there are other diagnoses that are very specific to the location of the organ that's helping the police with their inquiries. And so that may help you remember which quadrant the not to be missed diagnosis is associated with. And you might notice also that the only difference between the two lower quadrant lists is the addition of appendicitis to the right. And that the upper right quadrant has cholangitis as the distinguishing addition to its list of differentials. In fact, the right upper quadrant is one that is very specific. So pain in the upper right quadrant is normally going to be associated with either hepatic problems or problems associated with the gallbladder and the common bile duct. And just when you thought it was safe to go back in the water, here's a couple more to consider. So this time we're going to be looking at very diffuse and generalized pain across the whole abdominal area, as well as the area that's very specific, known as the epigastrium. Again, some of the things on the list are repeated, so again, not as daunting as it might first appear. Now, this might bring us to the point where you're asking, where can I find these lists? There are various sources for these. Perhaps one of the most accessible is via applications such as Diagnoses. Now, this particular app, and I'm not doing a commercial endorsement here, it's just the one that I use, and it's available on both Android and Mac platforms, and it allows the user to look up the differential diagnosis by either the primary complaint or by the assumed diagnosis. Now, one of the most valuable features is that it automatically compiles the not to be missed diagnosis list for most conditions or presentations. Now, if this sort of application is not to your liking, these lists can be found in published texts such as Taylor's Differential Diagnosis Manual, and this is available as an ebook in the ProQuest collection, and so it's available through the library at Whitireia. When we're investigating the character of pain, there's a couple of terms you'll need to be familiar with and understand, and these are going to help distinguish vital elements within an illness script, for instance, when it comes to differentiating between one condition and another. So the pain experienced during abdominal conditions can be grouped into one or more of three classifications, and each of these classifications relates to a particular nerve type or distribution. So being able to distinguish between the pain types helps to narrow the search for the source of the pain. And so let's go ahead and explore these three types of pain. So the first type of pain we're going to talk about is described as visceral pain. So in the most generalized sense of the word, viscera, we're referring to the organs within the abdomen. And in this setting, what we're going to end up doing is exploring the outer layer of the visceral peritoneum. That's the layer that covers the outside of the organs. Now, it's the activation of nerve receptors of this visceral layer that gives rise to what we call visceral pain. Visceral pain is a diffuse, generalized, and very achy pain felt when the stretch receptors of this lining, this visceral peritoneum, are activated. The pain will feel diffuse because these receptors activate multiple nerve pathways at the same time, so it's not really a singular message that's being sent. And further, these multiple nerve pathways enter into the spinal cord at multiple levels, anywhere between T5 and L2. So for the central nervous system, it may seem a little confusing as to where the pain is coming from exactly. The ascending path they connect to, this is the path that goes up the spinal cord, is thought of as an older and a more primordial pathway, and it has multiple terminations in the limbic part of the brain and fewer in the sensory and the frontal cortex. So the stimulation of the limbic brain promotes more emotionally dominant responses and less analytical ones. So this encourages feelings of misery when we have this dull, achy gut feeling. The multiple nerve pathways and multiple entry points to the spinal cord make it impossible for the central nervous system to pinpoint the exact location of the pain. This is amplified further by a relatively small number of these nerve connections that are going to terminate up in the sensory cortex. So to recap, visceral or visceral pain is associated with the activation of the stretch receptors on the visceral lining of the hollow tubes and solid organs inside the abdomen. The nerve pathways are such that they produce a very diffuse, generalized, achy discomfort that's hard to pinpoint in terms of location and tends to promote feelings of misery. Conversely, the nerve sensors and the nerve pathways that supply the parietal part of the peritoneum cause a different pain that we refer to as somatic pain. So the parietal part of the peritoneum is the layer that surrounds the gut or the abdominal wall. So in the last slide, we talked about the visceral peritoneum, the layer that was on the outside of the organs and the tubes themselves, while the parietal part of the peritoneum is one large sheet of lining material for the entire abdomen. The nerve fibers associated with this are the fast and bright alpha types, and they connect to both stretch receptors and to those specialized pain receptors known as nociceptive receptors that are on this abdominal cavity lining. The distribution for the somatic nerve pathways is far more singular in nature. So they're going to activate single nerves and they're going to enter the spinal cord at very specific levels instead of the multiple levels that were associated with the visceral pathway. In other words, there's less crosstalk between the nerves and the nerve signals enter the spinal column at one level only. Another distinguishing feature of somatic pain is its ability to be modulated. Now, pain modulation is a series of chemical alterations that are able to alter the transmission and the interpretation of pain. Now, an example of this is the release of natural opioids when nociceptive receptors are stimulated, and these, of course, are going to dull the pain response. Somatic nerve pathways have more connections with the frontal cortex, so this allows for analysis and rationalization of the pain. And whilst this may be subject to a range of idiosyncrasies, it might reduce the degree of suffering that people associate with this particular type of pain. The nerve pathway through the spinal column has a far more defined pathway leading to both the sensory and the frontal cortex. So the net result is when the somatic receptors are activated, the pain is more easily localized or pinpointed. Generally, it's also described as a sharper pain. The inference we can take from this is that in the presence of sharp and localized pain, we know that the parietal peritoneum has become involved. Now, this can be due to the presence of irritating substances such as blood or even air, and if not, it might be due to the inflamed visceral surface of an organ coming in contact with the parietal peritoneum. It certainly goes a long way to explain the nature of some presentations, and typically we can use appendicitis to describe this. So appendicitis starts with an inflammation of the appendix, and it's going to activate the stretch receptors of that organ's visceral peritoneum. Now, these nerve pathways are the ones that enter the spinal cord at multiple levels and have the majority of their terminations in the limbic part of the brain. Now, this is going to explain the miserable and diffuse periumbilical pain that accompanies the earlier stages of appendicitis. Now, should the appendix become inflamed and enlarged to the point that the irritation extends to the parietal peritoneum, the pain is going to localize to that area. So this gives rise to the classic right iliac fossa pain associated with the latter parts of the presentation with appendicitis. Now, before we move on from the pain associated with irritation of the peritoneum, or somatic pain, there's one other factor that's important to know. Generalized irritation of the parietal peritoneum often indicates the presence of a surgical emergency. So it's going to indicate there's a widespread presence of blood, or maybe digestive juices, or widespread inflammation that's causing this very widespread activation of all these somatic nerve pathways. As a general rule of thumb, this promotes really disproportionate levels of pain and tenderness associated with palpation of the abdomen. We also get that rebound tenderness. That's the tenderness that we don't associate with pushing down, but instead we get tenderness with a very fast release of a hand from the abdomen. And it can also promote a sign known as involuntary guarding. That is that rigid abdominal feel because the muscles have gone into spasm. And the last classification of pain we need to discuss is referred pain. So referred pain is defined as a site of pain that's distant or in a different location from the pathology that's actually causing it. This cause is likely to be due to how the nerve pathways are formed during embryonic development. Now, although the organs themselves might separate and migrate during the latter part of embryonic development, there are still common features in the nerve pathways that supply them. So this gives rise to pain that, despite it being caused in a particular location, is interpreted by the central nervous system as being somewhere else. Now, there are a number of classical radiation patterns for intra-abdominal pathology, and these include left shoulder pain associated with irritation of the left diaphragm or perhaps from the spleen. We have right shoulder pain that's associated with irritation of the right side of the diaphragm or the gallbladder. Upper back pain with gallbladder or common bile duct can occur, and it will also occur with perforated duodenal ulcers. Flank pain is often associated with renal or kidney problems, and inguinal pain with urinary bladder infections and ureter obstruction, and sometimes we can see it with ovarian problems or an ectopic pregnancy. And finally, as we've already discussed, we can get this periumbilical pain in the early stages of appendicitis. It's also important to remember that abdominal pain can come from thoracic pathology, and the archetypical example of this is an inferior acute myocardial infarction that may present with epigastric pain. Upper abdominal quadrant pain can also be associated with lower lobe pneumonia. Dissecting aortic aneurysms can also present with that very tearing epigastric pain, or it may include the patient having upper back pain. So, just recapping. While it's very easy to predict the location of an organ in the abdominal cavity, the location of the pain is not always an accurate guide to the location of the problem. Diffuse, generalized, and achy pain is likely to be caused by pathology within a solid organ or a hollow tube. Thus, inflammation of an organ such as the pancreas or obstruction of the small intestine can produce pain that is not particularly well localized. Colicky pain, that pain that comes and goes in waves, is normally a visceral pain, and it's usually associated with spasm or obstruction of a hollow tube. Sharp localized pain is more likely to be associated with irritation of the abdominal lining, that parietal layer. Referral patterns can help with differentiating features for some presentations. Shoulder pain, for instance, might be associated with a bleeding or infection of organs, such as the gallbladder or the spleen, and this has caused diaphragmatic irritation. Peritoneal signs tend to indicate widespread peritoneal irritation by blood, other fluids, or some form of infection. It's a worrying sign. Sometimes it's associated with abdominal rigidity or involuntary guarding, and often these patients will require emergent surgery. And finally, some intrathoracic pathology can cause abdominal pain, and thus the not to be missed diagnosis for epigastric pain is always going to include acute cardiac syndromes or perhaps a dissecting aortic aneurysm. Upper quadrant pain is sometimes caused by pneumonias. That's pretty much a wrap for this section. The skills associated with this presentation are going to include the skills required for a physical examination of the abdomen, and we'll be practicing these during class sessions. You're also going to need to develop some illness scripts to help learn the differentiating features of particular abdominal conditions. And at this stage, we're probably going to explore some differential scripts. And the purpose of the differential scripts is to compare and contrast the differentiating features of various conditions to help isolate a working diagnosis from a differential list. Well, I look forward to seeing you in class, and until then, ka kite.